Our first session today is about blood cancers. The way we understand and treat blood cancers is rapidly changing. This talk will explore how these advancements are expanding treatment options and shaping personalized care today. Our speaker today is Dr. Lee Yuh Shan, haematologist at Parkway Cancer Center. He specializes in blood cancers and advanced treatments such as stem cell transplants and CAR T cell therapy. He has spent over a decade at SGH, where he served as the director of the lymphoma service and lymphoma lead at the Singhal Duke Blood Cancer Center. Let's welcome Dr. Lee.
Hi, very good afternoon. Before I start, I would like to thank ladies and gentlemen. Thank you for spending your precious Saturday attending this talk today. And it is really a privilege to be able to share some of the experience or the treatment of this blood cancer with all of you today. This is just to give, in a way, showcase some of the cases and the advancement we have in blood cancer. As you all know, if you talk about blood cancer, it's actually a broad topic. So I just showcase in some of these different area. Mainly, we are looking at the blood cancer, which is acute leukemia, which is what most of us will correlate to when we talk about blood cancer. But actually, blood cancer has more than that. They have a blood cancer. You have a lymphoma, which is considered a type of blood cancer. And the last one is a myeloma, which is another type of blood cancer. So we'll showcase some of the 3 or 4 of the cases and see how advancement and how we can offer in Singapore in a more detailed kind of treatment and analysis of the disease. So this is a showcase. The first of the case is a 67 years old gentleman. Actually, he presented with this history of a seronegative rheumatoid arthritis, which was seen by rheumatologists and also some low dose this MTX. And he had this persistent thrombocytosis, means a high platelet after an episode of bleeding. Initially, I thought maybe this is from the bleeding, but the high platelet persisted. So I had to do some mutation study to show that, this is a type of mutation that caused the platelet to be high. And true enough, he has this mutation called JAK2. I think if some of you have been seeing some doctor, maybe this is something that you have seen before, heard before. Basically, when you see a high platelet or high white cell or high red cell, this is what we do. So initially, the treatment was quite conservative, but as the disease on the follow-up, you see got more other white cell, abnormal white cell. We proceeded with the bone marrow analysis. So bone marrow analysis showed that this patient truly enough have this myeloproliferative neoplasm, means a condition that actually proliferate a lot. So that's explain why his platelet is high. At the same time, we also have genetic mutation to show that he has another spectrum of disease called myelodysplastic syndrome. So it's a rare disease that you combine the two, on the one end high, the other end actually have been low. So this kind of condition usually it is associated with a poorer outcome. But initially when he's still well, you see the high the platelet number only without any low blood count. So actually we didn't do anything. This showed and when you do bone marrow study, right? Everybody will say, what is why is it bone marrow study so expensive? But we have a lot of tests when we do bone marrow. We look under the microscope, we do genetic mutation, we do flow cytometry, and usually typically this is the report of a bone marrow study if we do bone marrow. And this is a TREPHI, and more importantly, you can see all this fibrosis. It's important here that I will explain a bit later. So 1+ is actually normal. So we also nowadays we do more deep analysis of the genetic pathway or the mutation of a blood cancer, especially leukemia, and sometimes do for lymphoma as well. We're using this thing called next generation sequencing. Shown here is a normal karyotype 46XY, nothing significant. But if you do deeper analysis using this NGS, you can see the additional mutation study being done and show that the JAK2 is there. And interestingly, there's this thing called FSF3B, which is supposedly very sensitive to a medication to increase the hemoglobin. But his hemoglobin was well, so actually didn't do anything. So that confirmed this patient actually have 2 paths, myeloproliferative and myelodysplastic. One path increase the white count, the other path actually supposed to reduce the blood count and leads to blood cancer. So we didn't do anything, but from 2022 and 2025 conservative management until 2025, you started to have more tired with anemia, the hemoglobin low, and you can see that he have this thing called splenomegaly, the spleen enlarged, that you can palpate it, and with that actually he have a low appetite and other constitutional symptoms. So initially when you have anemia and with that genetic mutation, predictably supposed to respond to this medication called luspatercept. It's very specific for a mutation per se. It's supposed to respond. So we tried it, didn't work. So that actually, triggered the question whether there's some additional mutation. Since he has two, right? Maybe one side progressed further. And we did the flow cytometry. We showed that this is one of the things. There's no additional mutation. There's no increase in the leukemic cell, right? But we look at the trephine. From 1+ initially now become 3+. That I show you later. What do we mean by that? And NGS, previously you see 3 mutation, now you see 5 mutation. So what does it mean? It means there's some progression, right? There's a progression from 3 to 5. This means by genetic, even though the XY 46XY is still normal, but if you do deeper analysis, you can see there's definitely genetic mutation. This is called genetic evolution. And we have seen genetic evolution means the disease has gone more. And at the same time, what we see is a worsening fibrosis. That means the marrow cannot function. And we show that also the genetic mutation. So this patient have what we call that post-essential thrombocytosis, myelofibrosis. I mean, this is a very big word stuff. So basically, it shows that there's genetic evolution, which can easily be missed if we do not have this next generation sequencing correlation. So we say fibrosis. What do we mean by fibrosis? Imagine, this is a normal marrow, is a great one initially. It means the marrow can function, but when you progress, you can see that on the right lower hand side here, the whole thing become like a wiring. So basically, the bone marrow cannot function because it become hardened really. So this is what you see in some of the patients having this complex disease called myelofibrosis. And in myelofibrosis, usually patient become very thin with a big tummy because of the spleen, and they cannot eat much. And eventually they died of this bone marrow failure. So this patient not only has a disease like that causing the marrow to be hardened, at the same time he also at risk of getting blood cancer. So what to do next is actually blood transplant is the best option worldwide. Best option for him moving forward. There's a potential cure. So we actually try to look for donor worldwide. So we have a very good bone marrow donor program that actually support patients who is in need of this bone marrow donor. But unfortunately, because of this race, we couldn't find a 100% match. And we tried to give some disease to some chemotherapy, low dose to control, also cannot be controlled. So we decided to use the son as a donor. If you see as a son as a donor, instead of the brother who is in the 80 or 90% match. Why is it so? Because of the newer technology. So before I go further to this newer technology, we talk about this haploidentical transplant or graft versus host disease. If you look at the graft donor, we collect the stem cell from the donor, then we infuse into the patient. So when the patient's the graft wake up or grow up, right, they become a donor donor immune system will flow in patient's blood. But at the same time, patients seal their own body. You can see there's a mismatch. They are not the same. So when the immune system or the stem cell being donated wake up or grow up, they can recognize this is not their body, and they'll start to attack the body. They start to attack the patient's body or recipient body. So donor versus recipient. This is what we need, graft versus host disease. So how to avoid this? You have to find the best match, 100% or 90%. But in this era, we can do even 50%. This is what we mean by haploidentical transplant. How do we do that? This is the era where we talk about technology. We can use this technology we call T-cell selection. We can select out the cell that cause graft versus host disease. We eliminate them, and we actually select out those cells that actually cause engraftment of the stem cell. So we can have positive selection or negative selection. Maybe in the future, we can select younger cell to infuse for patient. This is just a joke. So this is what we're doing in Singapore. We are quite proud because this technology is not widely available worldwide. And the other cheaper way or more commonly way to do is what we call post-transplant cyclophosphamide. Means when the cell of this that can cause GvHD grow up, predictably around day 3, we give chemo to kill out this cell without causing much harm to the stem cell you receive. But, it's still a chemo, still got some side effects on the organs. So in Singapore, we are more keen to do this T-cell selection. But, if cost is a concern, sometimes we do give this post-transplant cyclophosphamide. So with this, we managed to actually give the patient, use a donor from the son as a donor, do hypoallergenic transplant. The good thing about this hypoallergenic transplant, the period of a low blood count is actually lower. The conventional way of doing transplant, you take about 21 to 28 days before the white cell count recover. With this hypoallergenic transplant, the chemo is lower, and actually patient engraft faster. So at the day 15, actually he went home, day 14, day 15, he went home already, and he actually then danced home from the but this PDP, so I couldn't show the video. But he's already back to work about 6 months after transplant. And immunosuppressant to suppress or to prevent this graft-associated disease already being stopped at around 3 months. As conventional way, you probably start stopping around 3 to 6 months. So about 3 months, you already stop everything. So this is what we call how technology, or how we can use technology to improve the outcome of patient and to use technology to detect earlier disease progression. This is not what I called saved by technology and medical improvement. It's what the brother told me. I realized, yeah, actually it's true. So we managed to detect a rare disease based on this genetic mutation, and we also, based on this NGS, we also managed to use haemolytic transplant, which couldn't be done previously. You talk about 10 years later, patient will be still searching for donor, and eventually you may use not the best donor, and the outcome may not be like that. Yeah, so this is what we've shown, that we can use technology to save patient. So shown here is how the diagnosis of AML changed currently. We are emphasizing more on the genetic mutation to separate patient, whether they have a high risk, intermediate risk, or a standard risk. We don't say low risk. Also, this is things that we are doing, and this is almost the standard that we do offer for patient if we do a bone marrow study. And of course, if the blood is circulating in if the abnormal cell is circulating in the blood, we can even do this study using the blood alone. And of course, I think you may heard of all this cell-free DNA, all those things to detect earlier disease. This is based on this technology called NGS. So with that, this is how we classify leukemia currently, AML, right? Based on genetic mutation. And of course, we are not going to detail, just a showcase, this is what we do currently. Yeah, and this is also how we assess a response. No longer we look under the microscope, or the leukemic cell is less than 1%, it's good enough. It's not good enough. Nowadays, we have to use a genetic mutation. Anything that was positive, it has to become negative. That is what we call negative measurable residual disease. It is so high, what do you call it? The bar is very high now. So this genetic landscape, not only we have the mutation study, or to be able to detect the genetic mutation earlier, we also have a landscape of medication that being approved currently. Singapore have probably, from off the FDA approval, we are getting it in earlier now. The only limitation now is because of the numbers, and we may not be able to get all of them. But if we have patients who need, we always write to the pharma to get this early patient access to get all this medication in. So that's about acute leukemia. So we're using more of a technology to detect the disease evolution, to detect the disease response, as well as classify the disease. And the same thing as acute lymphoblastic leukemia. Leukemia, we got AML, ALL. So it's also changed completely. Previously, we talk about, just chemo, transplant. But nowadays, the trend worldwide is getting the disease under negative MRD. And we may be able to avoid transplant if we have achieved this MRD. But of course, there's a new thing coming in, we call bispecific antibody, which is widely available in Singapore, now. And we use this MRD-guided genetic mutation or flow to guide how we're going to sequence the patient. Is it chemo, transplant, or chemo? Then you can follow up if MRD negative. So there's a trend towards using a better treatment to actually avoid the side effects of toxicity for transplant. Yeah, so that's an advancement in the leukemia. So for lymphoma, just a short, so change gear a little bit to, blood cancer is very wide. So we talk about lymphoma. So lymphoma, you have two main subtypes, Hodgkin, non-Hodgkin. Of course, you got different classification as well. This is not as simple. So if you look at detailed lymphoma classification, we have actually more than 100 classification of a lymphoma. So very blessed because our country has a very good pathologist and also all these scientists to be able to help us to actually diagnose the disease properly. In fact, in the WHO classification, one of the disease entity is the key person is from Singapore. Yeah. So for lymphoma, if you look at the non-Hodgkin lymphoma, these are the treatment available. This is just an introduction. The red color here is highlights what are the new things available in Singapore now, which may not be available in a regional country. And this is how we actually improve and actually push, the frontier, the treatment outcome further for an improvement with the patient's outcome. So on the relapse as well. So what is more important in the lymphoma? We always talk about this CAR T cell, but nowadays with the CAR T cell, another thing coming in which is called bispecific antibody, which is almost like a linkage between the immune system and the tumor cell. So these are available now. In fact, with lymphoma, we've got 2 or 3 available commercially as well. And in fact, for the indolent lymphoma or small lymphoma, we got oral medication to treat the patient as well. So this is a showcase one of the, because it's too long, we just, in summary, okay, this is a 45 years old gentleman who presented with this increased bubble in the urine. So further investigation showed that he got this kidney being obstructed because of the tumor in the abdomen. Shown here at the on the right hand side here, you can see a big tumor there with a a very light kind of color there. So that's actually that's why the kidney was injured because of this tumor. They cannot be blocked. It being blocked. The flow being blocked. So he got a stenting done, biopsy done. We show that it's a lymphoma. So we did further analysis. So this patient have a slow-growing lymphoma transforming into aggressive. We call aggressive lymphoma, this follicular lymphoma in transformation to diffuse large B-cell lymphoma. So we use the latest what we have, polatuzumab, in combination with the other immunochemo. This is about 2 cycles later, and you can see the treatment at diagnosis, and the red color is after 2 cycles of treatment. You can see all the red color mainly gone already. And if you look at the before treatment on the middle part at diagnosis, the black color one, those are the one actually showing this one, the metabolic disease. These all black color are not normal. These are the tumor, and you can see here these are normal. This is a bone marrow being active lah. So that's after 2 cycles with the new treatment we call polatuzumab. This is quite encouraging. So next case here, we're going to showcase how we actually do deeper analysis in Singapore here, and actually based on the physician. We don't look at just a diagnosis by pathology. It's always in discussion. 70-year-old gentleman presented with 1 month history of reduced appetite, back pain, lethargy with loss of weight. And he was seen by a general surgeon and noted to have this abdominal mass. So actually they did a CT scan which shows that he has a big tumor in the stomach, almost similar to first gentleman, suspicious of lymphoma. So we look at the blood film, they do a full blood count of the normal blood, and noted that actually the blood was not normal. So I did the bone marrow, and bone marrow actually showed this kind of changes. I'm not here to teach pathology, just show that sometimes in the good thing about hemato as compared to onco, we look at our own slides. So it means you do a bone marrow, you look at it, and you can recognize this kind of abnormal cells. So this is what we call lymphoma, abnormal lymphoma cell, but you can see some reculation here, like bubble inside here. So this typically when you read this, and then inside here, the bubble in the nucleus, when you see this, usually it's a type of malignant or aggressive lymphoma called Burkitt's lymphoma. So it throw, as I say, we also do other tests we call flow cytometry. We're quite consistent. So under the microscope, this flow cytometry are quite consistent with Burkitt's lymphoma. So 2 days after bone marrow, we did already. So the pathologist will tell you 1 week, no, after 2 days, we can start already. That's how fast you can move in for hematology. So started with steroid followed by full chemotherapy. Then what happened is the trafine came back as diffuse large B-cell lymphoma. Actually, they are still aggressive lymphoma, but if you want to be very, very particular about this, which I am, so they are different. Okay, they are treated differently. So I still believe in what I saw. So we discussed, and then we shared it. This is a trafine diagnosis, and I did further analysis we call fish study to prove that this is actually a Burkitt's. So this part here actually confirmed he has aggressive large B-cell lymphoma. And this part here confirmed that he has a Burkitt's lymphoma. So he has this very rare subtype of aggressive large B-cell lymphoma, intermediate between the Burkitt's lymphoma and the diffuse large B-cell lymphoma. It is a WHO classification, yeah, and its entity being recognized. And if you look at the karyotype of genetic mutation, he did highlight here is a translocation 814, recurrent genetic abnormality associated with Burkitt's lymphoma. So it's right, and the rest are not. The rest are just aggressive lymphoma. So unfortunately, this gentleman has this rare type of aggressive lymphoma. So this rare type of aggressive lymphoma, unfortunately, when they did all this study, this type of aggressive disease was excluded. So the conventional treatment is use epoch-R. So we know our data, and actually I didn't push for this, polatuzumab. We use a very simple this chemotherapy regime called epoch-R, and this is after 3 cycles. In the middle here, you can see all this very, very bright lymphoma. After 3 cycles, it's gone. So it's 70 years old. Actually, he still tolerated quite well. Yeah. So that's how a detailed analysis, a very good care, and close monitoring actually can tolerate. He completed about 6 cycles already, and now we're just waiting for the last scan now. So if we look at the lymphoma differently, we're actually quite grounded on the clinical details. Not all the medication you can be added on, no new medication you can be added on. Yeah. So we look at the details of the disease. We look at the patient itself. So the first patient actually have the disease we call transform to aggressive lymphoma, which can use this new treatment. The other one, unfortunately, this rare type of lymphoma, we still use this epoch-R. Yeah. So that's how we look at the lymphoma currently. Of course, everybody heard about this new hope for a patient using a CAR T cell, or we call chimeric antigen receptor T cell. Basically, they use a patient's T cell, genetically modify them so that they can recognize the tumor cell. They expand it, and then they actually, this is the process, infuse back to patient. So very high tech now. Last time we talked about one target. Now we'll talk about more than one target, CD19, CD22, and we will have additional medication to use to boost out the CAR T cell. We also have this super CAR that you can be produced, within the 2 or 3 days or within a week. Traditionally, it takes about 2 to 3 weeks to actually produce this CAR T cell. So there are a lot of innovation in CAR T cell. What we have is a very still the first line, but more is coming in the future. So this showcase one of the patients who unfortunately relapsed after the first cycle. 6 months, at 6 month time point, unfortunately he relapsed. You can see that the baseline here, that's a 6 line after 6 months of induction. He achieved complete remission, 6 months later relapse. So that's a poor prognosis. Any patients who relapse within a year. So actually proceeded with the CAR T cell, and this is the result after the CAR T cell. Only 1 infusion needed for this CAR T cell, right? And so finally, you talk about this multiple myeloma. We need to talk a little bit about multiple myeloma. I know the time is coming up already. Mainly because we have an aging population, and this myeloma is usually associated with aging population. And this is called by a cell called plasma cell, which produce antibody like that. But when they become abnormal or cancerous, they produce only 1 type of antibody. And this 1 type of antibody can cause all the kidney failure, can cause bone fractures, etc. So in this timeline, right, if you look at landscape, we don't talk about chemotherapy anymore. For myeloma, everybody talk about targeted treatment. You don't talk about chemotherapy at all. And the outcome is still very good. So this is another case that I went to in and out ICU 3 times. I thought I almost lost him. So 55 years old, presented with reduced effort tolerance, chest discomfort. See my cardiologist, the cardiac enzyme raised, they thought it's heart attack. So they actually did the stenting. Then realized, actually the heart wall looks a bit big. And you look at the tongue like Buffy, we call beefy tongue, very big. So this very commonly seen amyloidosis. So actually, with all the analysis confirmed is amyloidosis, we started treatment. This is 1 day after treatment. Suddenly abdominal pain, had to rush to A&E, and we immediately did a CT scan. We show this perforation of the bowel. So only 1 day after treatment, not because of the treatment, it's because of the disease. It's tumor load, the amyloid already affected the heart, the gut, the kidney. And hence the gut is very viable. You can see here, sorry to this photo during lunchtime. Yeah, we are not providing any of this, but on the right hand side here is his amyloid gut. You can see very fiber, like very angry looking. This very friable kind of amyloid. How to treat like that, right? So we actually stopped treatment for about 2 weeks. So he was, of course, admitted to ICU after surgeon. The surgeon don't even dare to put in the gut bag. Had to be exposed, cover it up. Every day examine until 2 weeks later, then only managed to put it back into the stomach. And yeah, we can do that. But of course, need the experienced surgeon to do that. So treatment suspended. Of course, condition complicated. The thing is that if you don't treat, There's only one way to go, right? So we had to treat gingerly. Good thing is that we have this antibody-based treatment, which don't cause much side effects, CD30 antibody. So we managed to discharge him 6 weeks from the surgery. And I thought, we've gone through it already. Then he come in again with the bleeding, the gut bleeding again. So I admitted ICU in and out 3 times. I feel so bad I had to write to the insurance before they asked me, because this in and out. But the good thing is with multidisciplinary team effort, the renal, the intensivists, we managed to pull, and cardiologists, we managed to pull him out from this treatment, and he eventually the kidney improved, he passed urine, and with the treatment, this is showed how we assess the response. The light chain from very high, about 5 months later, normalized already. And how about him? He actually completes the treatment now, maintenance already. So from bed bound to become wheelchair bound, to become walking frame, and now he's walking on his own. Of course, off the records to actually drive a little bit as well. So he's back to his lifestyle, managing his own business again. And the first thing he tell me, wow, he can taste the food now. When he amyloid the Buffy code, he cannot taste any food. But he just eat to survive, but now he can enjoy his food. So that's what we can offer here, 4 cases of complicated cases and how medical advancement can actually help patient. And of course, we offer a very timely diagnosis, very, very fast actually. In fact, you go to other countries, you don't find so fast. And cutting edge technology as well as therapies and well-experienced physicians who work closely as a team. Of course, I know we are in most of the insurance panel, and we work closely with most of our insurance partner for our patient. So the final thing is that, each patient is not just another case to us. They are a patient with a beloved family, with the journeys and the dreams yet to be fulfilled. So what we are trying to do is that we're trying to make them better so they can actually make this fulfill their dream. And with that, I thank you for all your attention. Yeah.
Thank you so much,